Some of you I may not really quite recognize. Miss Sylvia,
Good morning.
good morning. I wonder, let's see. Gallery. Six, nine. Excuse me, I was just looking at something. Red list.
Mr. Weaver, you got my camera to work, so it's on out for you.
I'm sorry, say that again, Miss Althea. Oh, is that you, Miss Ham?
Yes, sir. I just got my camera to work, so see, I turn it on.
Oh yeah, I appreciate it. All right, thank you. All right, you're good. Miss Manders. Right. Miss Legger. Are you all able to make your rooms dark like that? I wish I could make mine dark like that. That probably wouldn't be acceptable though for me. Miss Singh. Oh, you did the same thing. How y'all do that?
My room is naturally this dark. I don't know. It's weird.
Yeah. Ms. Austin. Ms. Taylor.
I'm here.
All right. So just so you all know, it appears that you all have received my my announcements over the weekend, which I'm sure I sent several. So it appears that there's quite a few issues with people coming into campus, and so I'm going to have to scratch coming on campus and doing the test virtually. However, everyone would just have to be on camera at this point. Yeah, everyone will have to be on camera. Yeah, there's just too many issues. And I realized it was kind of at the last minute. And I told you all back then, or a while back, that we would give you ample time. Due to the circumstances, I found that I needed to have a certain number of people on campus so that we can kind of squash some of the things that has been happening, that have been happening. But again, due to all of the issues that have been occurring, just have to be flexible. So, and of course, what I say to you, I'll make sure I let everyone else know. I know that there has been several issues with coming on campus, but keep in mind, you will have to come on campus for your final HESI for sure. Everything else I'm able to be flexible with. But coming on campus for your HESI, which would be in the 10th week.
Do you have a date?
Let's see, what's my schedule? It would be the week of the 13th of July. That's the beginning of the week, but let's see, July 13th. That should be the 15th. Because we're trying to bring students back on campus to do the exam the day that they would normally come on for their lecture.
What
so
time?
Should be 10 o'clock. Yeah, your time is 10 o'clock usually. Yeah, because class for you is 10 to 2:30. So it'll be 10 o'clock. I could possibly, technically, I can probably push it to around maybe 11, but let me check into that first. I do know it will be on the 13th, and it will be between class time.
Professor,
Yes.
we will be back on campus next term.
You know, I don't know, to be honest. Did you hear that?
Yes, sir.
Where'd you hear that? It could have been in my emails. I haven't really been able to check a lot of it this weekend.
Oh, no, I didn't hear that we'll be on campus. I thought you were asking me if I heard you reply to me.
Yeah, not really quite sure 100%, but there was an email that went out this, last weekend from Mr. Ray. So I would need to look to see exactly what he is saying. Let's see. It was something that was said about wearing masks, and maybe, you know what? It couldn't have been a weekend. Maybe, oh, yes, it has. Campus updates. Yeah, I will have to go ahead and read this. What is this? 26. Friday. Yeah, so anyway, I was able to be more flexible this time around, and I know that the proximity or the time that I indicated was a little close. Yeah. Says safety goggles will soon be required in all labs and classrooms. A shipment of these goggles will be arriving within the next few weeks and distributed to each program director for distribution. So it appears that whenever we do come back on campus, y'all are going to be wearing goggles in the classrooms and labs. Anyway, I guess we'll speak more on that. Show me full screen. And I was just trying to see something. Second. All right, class, as a, or before I get into the whatever concept maps we'll be doing today, what I would like to do hold just a minute. I want to see something. Make sure I don't kill you all today. All right, that's not too bad. Yeah, I was trying to figure out which topic I wanted you all to look at. And so we'll looks like we're going to do myasthenia gravis after pre-conference. But in the meantime, since this is your clinical course, or your clinical, what I want to do, usually I like to try to play these videos while, well, play it on my end so that you all can watch the video. But I don't think the volume works very well when I do that. But just for the heck of it, let's see. All right, I'm going to go ahead and play this video. So let me know if you all can or cannot hear it.
No,
Can't hear it.
no.
All right. All right, so I kind of had a feeling that would happen. So what I'm going to do, you all have access. Who doesn't have access to their announcements right now? You should, since you're sitting in front of your systems.
When you share your screen, did you click the box that says share audio, include audio?
Now say that again.
Go on share, share your screen, and then you're gonna see like a small tiny box on the upper right hand that says include audio. And then
Turn off incoming video. Is that the turn off incoming video?
no, share, act like you share it. And then you're gonna see a tiny box that says include audio.
Let me try that. Let's see. Yeah, for some reason I'm not seeing it. Now, you're saying that this would be at the top right-hand corner?
You know when you're sharing your screen and then it asks you, do you share if you want to share your desktop, it give you the option. There's like a small box and you check it for include audio.
Oh, I see it. It's over here to the left, actually.
Yeah. And be able to hear it.
Oh, that's interesting. Thank you for that. How long you knew that?
Miss Bodie.
No. Nobody ever told me that. I did it before on Zoom, but I was never able to duplicate that on Teams. So, all right, let me try it again. Tell me if you can see it.
You're going to inspect it, then palpate.
We hear it.
And then auscultate. Except you're going to.
All right, so I was looking at this one video last night, and that one was actually 30 minutes. Although I think she did a fairly decent job. What I like about this particular one is that this young lady actually shows you the different landmarks of where your stethoscope should be placed, where you should be listening, and so forth. And so I thought this one was better. It is 41 minutes. So, I mean, we have time, right? This is a pre-conference. But what I want to do, there's two reasons I want to do this. Number one, of course, this is a clinical class. And so when you go into your patient's rooms, you have to be able to assess them. Now, the other part of that is next term, you guys will be taking a health assessment as well as mother and baby. And so I want you all to get a sneak preview as to what you're going to have to do next term. Some of you probably already watched this video already. I don't know if Professor White showed this to you, but a refresher doesn't hurt at all, trust me. And you all will have to do a complete head-to-toe assessment next term anyway for a grade in order to pass that particular course. So let's go. I'm going to go ahead and start to play this video. And if you all can listen closely. Let me see if I can expand this. And that way, we will become more familiar with how to do an assessment. Now, let me say this to you. Pay particular attention to the cranial nerves. So we're talking about 12 cranial nerves that you will see her assessing. You are going to see this again. Some of these, this entire assessment you will not do each and every day when you go into your patient's room in the acute care hospital setting. Quite a bit of it you will, but there's quite a bit you won't. But still take it all in because you will have to do it again at some point.
Dr. Reaper, about again today?
Want to say again?
I said, what disease process are about again today?
Myasthenia gravis.
Okay.
Yeah, a very interesting disease actually. But we'll start that, of course, after your pre-conference. And who was this? Was that Miss Singh?
No, that was Gabby. I was just.
Oh, all right. All right. I'm sorry, I don't recognize you all's voices at this point. You know, I teach a virtual class, an online class at the University of Southern Indiana. And, you know, that's fine and all because that's expected. But I don't really like virtual for classes that should be on campus. You know, can't see you all and really engage like I want to. But this is our life today. All right, I'm going to go ahead and start this. So just take a listen. And forgive me if some of you are irritated with her voice. I think it's kind of cute, you know, Southern kind of tone.
Assessment. This video will be similar to what you have to perform in nursing school whenever you're doing your clinical checkoff. Now, whenever you actually start working as a nurse, you'll be able to tailor this head-to-toe assessment to focus on the patient's needs, and you'll get a lot faster at this. So what I want to do is I want to cover literally how to assess from the hair on the head all the way down to the toes. So let's get started. Now, when you're doing your head-to-toe assessment, you follow that sequence of how you assess each system. So you start out whenever you're looking at a system, you're going to inspect it, then palpate, percuss, and then auscultate. Except you're going to change it up a little bit whenever you're going over the abdomen. You're going to inspect, auscultate, percuss, and then palpate. And the reason that you're going to auscultate second instead of last is because whenever you perform palpation percussion, if you did that before, it could alter the bowel sound. So we want to go ahead and just auscultate, get a baseline of what we can hear, and then we will percuss and palpate. So first, what you want to do is you want to perform hand hygiene and provide privacy to the patient. Then introduce yourself to the patient and explain what you're going to be doing. So hello, my name is Sarah, and I'm going to be your nurse today, and I need to perform a head-to-toe assessment. Is that okay with you?
Yes.
Okay. Then proceed and look at their armband. So while you're doing this, this is going to help you make sure you have the right patient, and you're going to be testing them to see if they know who they are, their date of birth, and ask them some other questions to assess that neuro status. So state your first and last name for me.
First name is Ben, last name is Dover.
Okay, and your date of birth?
8/28/82.
Okay, and do you want me to call you Ben or Mr. Dover? What do you
Ben
prefer?
will be fine.
Okay, so Ben, can you tell me where you're at?
I'm at the hospital.
Okay, and can you tell me what we're doing here today?
Head-to-toe assessment.
Okay, and who's the President of the United States?
Donald Trump.
Okay, so he answered all of those correctly, and he's alert, and he's oriented ×4. He knew who he was. He was able to tell me his name, his date of birth, where he was, what we're doing, and current events. So we can chart alert and oriented times 4. Then you'll want to collect vital signs such as the patient's heart rate, blood pressure, temperature, oxygen saturation, respiratory rate, and the patient's pain rating. So Ben, are you having any pain on a scale 0 to 10, with 0 being no pain at all and 10 being the worst pain you've ever had?
No pain, 0.
Okay. And I have a video on how to assess those vital signs in depth if you want to watch that video, and a card should be popping up so you can access that video. Then after that, what you want to do, you can collect their height and their weight and look at the BMI, their body mass index. Remember, if it's 18.5 or less, that's underweight, or if it's greater than 30, that is obese. Now, while you've been doing all that, asking them these questions, doing their vital signs, you're also, before you've even really assessed the system, you are already collecting information. For instance, how is that patient responding to you? What's their emotional status? Are they calm? Are they agitated? Are they drowsy? What's going on with them? Do they look their stated age? Does his skin color match his ethnicity? Does he understand my questions, or does he seem like he can't hear them very well? Or is there a delay whenever he responds to me, or does he respond appropriately and at an appropriate time? Also, do you notice any just outward abnormalities like an amputation, any masses, lesions? Is his skin sweaty, cold and clammy? Do you notice any cyanosis right off the bat? Also, is his hygiene good, and is his posture good, and do you notice any abnormal smells? So during all that, you're really collecting all that information. Now what we're going to do is we're going to start with the head and move our way down to the toes. So we are first going to inspect the head, and we are looking at the skin color. It's nice and pink. We're also going to make sure that the head is the same size as how it should be for the body, and it is. And we're looking for any abnormal movements or twitching of the face that he can't control that are involuntary. We don't see anything. And we're making sure that the face is symmetrical. There's no drooping on one side. Like in this picture, there's drooping on one side of the face, and this can be seen in Bell's palsy or in stroke. And we're also just looking at the eyes and the ears. Are they at the same level? And while we're here, we're going to go ahead and look at the facial expressions and test cranial nerve 7, which is the facial nerve. So can you close your eyes tightly for me and open them up? Okay. Now smile for me, frown, and puff out your cheeks. Okay.
We can't hear you.
Yeah.
Uh-oh, I'm so embarrassed. Yeah, I was saying, make sure, as you've heard her, you're looking for symmetry, like when the patient smiles or frowns, everything is moving at the same time and is in the same position. That's very important as you assess the patient's cranial nerves or any part of the body, even the left and the right arm or left and right leg. Everything has to be symmetrical. Even in strength, it should be all symmetrical. So keep that in mind. And also, as she mentioned, you're assessing, even though she asked him about who is the president and what's your name and where are you and so forth, just doing a regular conversation with the patient, you can pretty much determine if the patient is really with it. So you're always making these observations with your patient, just with your regular interaction. Just like when your patient come into if you're working in a clinic, for example, you're looking at this patient's gait. The patient doesn't know that he or she is being assessed, but you're actually assessing the patient from the time they walk into the room, the way they sit down, the way they get up. So, and another thing with your assessments is you want to try to get cover as many areas of the body while the patient is in a certain position. In other words, you don't want the patient to, you assess the patient like, let's say if you assess the posterior chest, all right? And then you have the patient get up and do something else, and then you have them resume that position again so you can look at something else regarding the chest. Then you have them get back up and do something else, and then get back down and assess another portion of the chest. In other words, you got this patient up and down, and you'll learn in health assessment next term, especially with these elderly patients, you can't have them up and down, changing all these positions and whatnot. So you want to try to do as much as you can in various positions, and hopefully she'll go over that as well. I don't quite remember it from this video. She probably did, but just to kind of alert you to that. You're making it as convenient as possible for the patient without wearing them down, especially your elderly. All right.
Okay, and he did that with ease, so that cranial nerve is intact. Next, what we're going to do is we're going to palpate the head, the cranium. We're going to check for any masses, indentations, look for skin breakdown, any infestations. And for this part, I like to wear gloves. So let's look at the hair. So what we're doing is we're feeling for any masses, indentations, and also with this, we're looking for any skin breakdown. And if your patient's immobile, you really want to check the back of the head back here because they're laying on it a lot and there can be breakdown back there. Also, while you're doing that, look inside the hair. Make sure there is no infestations like lice, and there's no abrupt, like rounding areas of baldness, which could represent alopecia. Then after that, since this patient has a beard, you want to check the beard as well, any lesions, any infestations or anything like that, and just look around. And then once you're done with that, what you want to do is you'll doff your gloves and perform hand hygiene. Next, what we're going to do is we're going to find the temporal artery and we're going to palpate them bilaterally, and they are both found right here. And his are about a 2+. And then while we're right there, we're going to go ahead and test cranial nerve 5, which is the trigeminal nerve. And this nerve is responsible for many things like mastication. So what I'm going to have you do, Ben, is I'm going to have you clench your teeth, like bite down for me. And I'm going to feel the masseter muscle, which is right there, and it should be a nice firm ball. And then feel the temporal muscle. Now what I'm going to do to also test that nerve is have him try to open his mouth against resistance. So try to do that for me. Okay, and he can do that. Now, while we're here, we're going to go ahead and feel the temporal mandibular joint. And we're going to feel right here, and I'm going to have you open and close your mouth. And I'm feeling for any grating or clicking sensations, and I feel none. Then we're going to palpate the sinuses, and I'm going to put pressure on these two sinuses right here, and you tell me if you feel any pain, okay?
Oh, again, pay attention to the cranial nerves when they come up, because you will see this when you get into a health assessment. And so just really pay attention to that. Very important.
So the maxillary
No.
and the frontal.
No.
Next, we're moving down to the eyes, and we're going to inspect the eyes first. And we're looking at several things. We're looking at the eyelid. We're looking at the sclera, which is the white of the eyes. We're looking at the iris. We're looking at the pupil, and we're looking at the conjunctiva. So you shouldn't see any swelling of the eyelids. You should see that the sclera is white and shiny. It shouldn't be yellow like in jaundice. And the conjunctiva, when you pull down the lower lid, have the patient look up, it should be nice and pink. It shouldn't be red. You shouldn't see any drainage or anything like that. Then look at the eyes. How do they set in the eye socket? Are they equal? For instance, is there any strabismus? Is there a cross eye where one eye turns in more, turns out or up or down? And these eyes are normal. There's no strabismus. Next, you want to look at anisocoria, where one pupil would be smaller than the other pupil. Are they equal in size? Normal pupils should be 3 to 5 millimeters in their measurement, and here his are about a 3, and they are equal. Next, what we're going to do is we're going to assess some cranial nerves. We're going to be looking at cranial nerve 3, which is ocular motor, 4, trochlear, and then 6, which is abducens. And we're going to do several tests to check their function. The first one, what we're going to do is we're going to be looking for any involuntary shaking of the eye called nystagmus. And how we're going to do that is we're going to take our pen light, we're going to hold it about 12 to 14 inches away from the patient's nose. And Ben, what I want you to do is keep your head still, don't move your head, and just use your eyes to watch where I move the pen light. And as you're doing this, you're going to perform it in the 6 cardinal fields of gaze. And you're just going to move it, and you're looking for any involuntary shaking of the eyes. So here we go. Next, we're going to see how reactive the pupils are to light. And to do that, we're going to dim the lights a little bit, and we're going to have the patient stare off at a distant object that helps dilate those pupils. And then we're going to shine, using our pen light, in at the side. And we're going to see how that pupil responds. It should constrict. And then on the other side, it should constrict as well. So say their baseline pupil size was like 3 millimeters. It should go down to 1 millimeter, and it should happen on both sides. Okay, so Ben, stare off at that object right on the wall over there for me. Okay, and that dilates the pupils, and we're just going to shine light in at this side. Okay, constrict, constrict. Okay, dilate again, and then go to the other side. Do the same again. And they both constricted in equal size. Next, what we're going to do is we're going to check for accommodation. And how we do that is we turn the lights back on. We just previously had them dim, but we now make it light again. We're going to have him stare off at a distant object that helps dilate the pupils. And we're going to take a pen light. You can use a pen light finger, and you're just going to slowly move it inward to the nose. And what you're looking for is that those pupils constrict, they accommodate, and the eyes cross while looking at the pen light. So here we go. Stare off in the distance, please. And I don't want you to move your head or anything. Just keep it real still and just follow this pen light, okay? Ready? Okay. So now we can document, because we just checked all of the things with the eyes, we can document that the pupils are equal, round, reactive to light, and the accommodate. So that's where that acronym PERRLA comes into play. Next, we're going to move on to the ears. So first, what we do is we inspect the ears. We look on the outside of the ear. Is there any abnormalities, any redness, any drainage, anything like that? And Ben, are you having any pain in your ear? No. Okay. And sometimes if you have patients who've had long-term gout, on the helix of the ear, they may have what's called a tophi, which is an accumulation of like a whitish, yellowish uric acid crystal on the skin. So if you ever see that, that is what that looks like. Next, we're going to palpate on the ear. We're just going to move it around. And Ben, tell me if you have any tenderness whenever I do that. And feel any abnormal masses or lesions, and then move the targets a little bit. Does that hurt or anything like that? No. Okay, so no pain or tenderness. Then we're going to palpate the mastoid process, which is the big hump behind the ear, and we're looking at it. Is it swollen? Is there any redness? And whenever I touch on it, Ben, does it hurt? No. Okay, and just see if the patient reports any tenderness with that. Then while you're there, you can use the otoscope to inspect the tympanic membrane. And remember, the tympanic membrane should be a pearly gray translucent color and should be shiny. So for an adult, you're going to pull the pin of the ear up and back. And we're just going to inspect it. And also, while we're looking at that, we are looking at the cone of light. And remember, the cone of light in the right ear should be at 5 o'clock, and in the left ear should be at 7 o'clock. Next, we're going to do one more thing with the ear. We're going to test cranial nerve 8, which is the vestibulocochlear nerve. And
hey everyone, make sure when you insert this instrument, the otoscope, the cone portion into the ear, be very careful, because if there's some kind of pathology going on within the ear where the patient has a lot of pain, you could bring about a pain response even the more if you're not careful. So just be very gentle when you do that particular part of the exam.
And what I'm going to do is I'm going to include one of his ears and then whisper 2 words on the other side. He needs to tell me what I said. So you ready?
Mhm.
Okay, I'm going to include this one.
Apple, banana.
Okay, very good.
Cat, dog.
Okay, and that nerve is intact. Next, we're going to move on to the nose, and we're going to inspect the nose. We're going to make sure it's midline on the face, which it is. We're going to look at the septum. Is it deviated, anything like that? And ask the patient, are you having any trouble with your nose? Are you having any drainage or anything like that? No. And you want them to you want to check the patency of the nose. So then I'm going to have you occlude one side of the nostril, breathe out the other, and vice versa. Okay, heard airflow. Airflow, nice and patent, because sometimes people can have polyps that can block it or the deviated septum. Then you want to take your pen light and you just want to look inside the nose, look for any drainage, redness, or any like polyps or anything like that. And everything looks clear, I don't see anything. And then we're going to test the olfactory cranial nerve 1, the sense of smell. So Ben, what I'm going to have you do is I'm going to have you close your eyes and I'm going to put something in front of your nose and have you breathe in and smell, and you tell me what you smell. And whenever you do this, use something that's pleasant smelling, not something that's really stinky, because it could elicit like a gag reflex or something like that if the person has a sensitive nose. Okay?
Vanilla.
Okay, and this was vanilla extract, and that is correct. So that cranial nerve is intact. Next, we're going to move on to the mouth. And for this part, like to wear gloves. And if your patient is coughing and hacking, you might want to wear a mask with a shield so you don't get any mucus on your face or in your mucous membrane. So first, what we're going to do, we're just inspecting the lips, make sure they're a nice pink color, they're not chapped, there's no sores on them. And one thing with a lot of patients, whenever their oxygen saturations are low, their lips may turn dusky or a blue color. So you want to make sure they're nice and pink, because that can represent our oxygen level. Now let's inspect the inside of the mouth. But first, let's test cranial nerve 12, which is the hypoglossal nerve. And what I'm going to have you do, Ben, is I'm going to have you stick out your tongue and move it side to side. Okay, and he does that with ease. Now what we're going to do is we're going to inspect the inside of the mouth. You'll need a tongue blade for that. And just open up your mouth for me. And I'm going to look on the inside of the cheeks, nice and pink. Don't see any sores. You're looking to see if they're nice and pink and there's no lesions or anything like that. And stick out your tongue for me. The tongue should be moist like this and pink. You don't want it to be beefy red, which is like in pernicious anemia. You don't want it to be dry or cracked. That could be dehydration. Okay, you can put the tongue in. Then I want you to lift up your tongue for me and look for any lesions underneath the tongue. That's where mouth cancer can hang out, and I don't see any. Okay, you can close. Then while you're also looking at the gums, open up a little bit. You're going to look around for cavities, any loose or broken teeth, no dental caries in there. Then, okay, sort of open up your mouth a little bit more, put your tongue down, and you're going to look at the soft and hard palate. Now, while you're in there, you want to look at the uvula. Make sure it is nice in midline, and his is nice in midline, and we're going to test cranial nerve. Hang out, and I don't see any. Okay, you can close. Then I
just want to show you all something real quickly.
While you're also looking at the gums, open up a little bit. You're going to look around for cavities, any.
All right, this is the uvula right here. And when you put the tongue depressor back there on the tongue and you tell the patient to say, ah, I don't know if you all can see this, but the uvula should go up and down and remain in a neutral position. You know, it should be symmetrical on both sides. It shouldn't deviate here or over here, but it should just go up and down when a patient goes, ah.
Loose or broken teeth, no dental caries in there. Then, okay, sort of open up your mouth a little bit more, put your tongue down, and you're going to look at the soft and hard palate. Now, while you're in there, you want to look at the uvula. Make sure it is nice in midline, and his is nice in midline. And we're going to test cranial nerve 9, the glossopharyngeal. And so what I'm going to do is I'm going to have you say ah. And what you want is that uvula to move up. Okay, and then we're just going to test the gag reflex. I'm sort of just going to poke a little bit back there and elicit a gag reflex.
Be careful with that.
There you go. Gag's really good. And cranial nerve 10, the vagus is intact because he's able to talk to me without hoarseness, and he's able to swallow. Then when you're done inspecting the mouth, be sure you take off your gloves and perform hand hygiene. Now moving on to the neck. So what we're going to do is we're going to inspect the neck first. So you're going to have the patient extend the neck up a little bit, and you're looking at that trachea. Is it midline? Look for any lesions and look for any lumps, like what you might see in thyroid problems like a goiter. And we don't see any of that. Then what we're going to do is we're going to test cranial nerve 11, which is the accessory nerve. So Ben, what I'm going to have you do is move your head side to side, up and down. Okay, and then shrug, try to shrug against my resistance. And he does that with ease, so that nerve is intact. Then we're going to place him at a 45-degree angle, and we're going to have him turn his head to the side. And what we're looking at is the jugular vein. We're looking for any jugular vein distension.
Remember JVD when we look at which heart failure, left or right? Where would you see JVD or jugular vein distension? Which one? Either right or left heart failure. Anyone? All right, it'll be right. Yes, right. So right side of heart failure. So this is what she's doing. If it's distended, it could be possible that the patient is in heart failure.
So then I'm going to just turn your head to the side like that, and we're looking for any distension of the vein, and we do not see any. Next, what we're going to do is we're going to palpate. So we're going to palpate that trachea just to confirm it is midline. And Ben, do you feel any tenderness or anything like that? Ask him if he feels any tenderness. And I don't feel any lumps. Then next, what we're going to do is we're going to palpate the lymph nodes, all sites of those. And Ben, as I do this, tell me if you feel any tenderness.
This is very important here. Pay attention to how she assesses the lymph nodes. You will do this again.
And what I'm feeling for is any hard lumps or anything that may be inflamed. So what we're going to do, turn a little bit this way. And here we go. We're going to start at the pre-auricular, which is right in front of the ears. Then we're going to go to the back of the ears, the post-auricular. Then we're going to go to the occipital, the parotid, jugulo-digastric. Then we're going to go to the submandibular, and then the submental. Then we're going to go to the superficial cervical, and then we're going to make our way down to the deep cervical chain. Any tenderness so far? Then we're going to go to the posterior cervical, and then right above the clavicle, we're going to go to the supraclavicular. And did not feel anything and no tenderness. Next, we're going to palpate the carotid artery, and this is one artery that you do not palpate bilaterally, you do one individually. So we're going to feel on this side, and you're going to find it next to where the groove of the neck and next to the trachea, and his is nice and bounding, it's 2+. Then we're just going to feel on the other side, and same strength, 2+. Then lastly, what we want to do is we're going to auscultate the carotid artery, and you're going to do one side at a time, and you're going to compare sides. And you're going to listen with the bell of your stethoscope, and we're listening for a bruit, which is a swishing sound. So Ben, what I'm going to do is I'm going to have you breathe in, breathe out, and hold it for me, okay? Go. Breathe in, breathe out. Okay. Breathe normally now. Did not hear it on that side. Okay, breathe in, breathe out for me, and hold it. Okay, and I did not hear a bruit on that side as well. Now let's move to the upper.
So when she puts the small of that stethoscope, or the small side of it, which is the bell, onto the carotid arteries, if she was to hear a sound like a whoosh, 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 it basically means that his blood vessels, there's a blockage in there somewhere, not perhaps a total blockage, but it's a narrow, something we may call like a carotid stenosis, maybe a lot of plaque from arteriosclerosis, atherosclerosis, excuse me, that the patient may have. And so that blood is rushing through that very small space. So this is when we talk about the patient has a bruit. And so they do other diagnostic tests, more sophisticated tests, to determine how stenosed or narrow that area is.
Extremities. So what we're going to do is we're going to inspect the extremities, and we're looking for any lesions, any redness, swelling, and this is a good time if they have a central line, an IV, that you look at that, make sure it's not red. Does the IV need to be changed? Does that PICC line or central line need a dressing change? Assess that. Then you can palpate, and what we're going to do is we're going to palpate our pulse, our radial artery. So feel those bilaterally, and they are 2+ and they're equal. Then we're going to check capillary refill, and to do that, we're just going to press down on that nail bed and see how fast it comes back, and it's less than 2 seconds. Then we're going to check skin turgor by just pinching the skin and see how fast it goes back, and that was good. Then we're just going to look at the range and the motion of the fingers and the hands. Look at these joints in the hands. Do you see anything abnormal, like for instance like Herbadine or Bouchard's nodes, which are found in osteoarthritis? And ask the patient, are you having any pain in your hands or anything like that? No. Then you can palpate the brachial artery, which is found in the bends of the arm, and just feel those because that's another pulse site. And those are 2+. And just as a side note, if this was a patient that was getting dialysis and they had an AV fistula, you would want to palpate that and feel for the thrill, make sure that that is present up in that arm wherever their fistula is at. Then you want to test the muscle strength. So
does anyone know when you're assessing that AV fistula, we talk about a thrill or a bruit? Does anyone know what that is? Because you're checking for both. Anyone? All right. So when you use your stethoscope to when you place it over the AV fistula, you'll hear this kind of rushing kind of sound of blood, and this is what is referred to as the bruit. All right. And when you take your hand and you place it over the AV fistula, it'll almost feel like, you know how when you, like something like it's vibrating, kind of has a vibrating kind of a feeling. And so you're palpating with your hand, that's the thrill, right? So you're looking for thrills and bruits as it relates to your AV fistula. And always make sure you're looking at your patient's arms to determine this, to determine if they have one. because you don't want to place not a stethoscope, a blood pressure cuff on an arm that has an AV fistula in it.
What we're gonna do is I'm gonna have you squeeze my fingers as hard as you can, okay? Okay, that's really good. Then I'm gonna have you push up against my hands and I'm gonna push up against your arms, okay? Push. Okay, very good. Okay, and 5+ normal strength. Then we're just gonna test put your hand underneath the elbow and just feel as you move the arm. Do you feel any grating, crepitus of those joints? A lot of times in arthritis, you can feel that, and move that bilaterally. Another thing you want to do with the upper extremities is to check for a drift. And what you will do is you'll have the patient hold out their arms and close their eyes, hold it up for about 10 seconds, and you're looking for a drift like this. So go ahead, do that and close your eyes, okay? And we're assessing to see if this hand will drift upward. And a lot of times, if a patient has had a stroke, okay, you can put the nail on, has had a stroke or something like that, you will see a drift. Next, we're moving on to the chest, and we're going to inspect the chest. We're looking for any abnormalities like lesions or any.
Before we go to the chest, I just want you, because I don't know if I saw her do this, I don't remember. As far as the neck is concerned, when we are checking cranial nerve 11, this deals with the neck. And so what you're testing for is the range of motion and muscle strength against your resistance. So what you might do is place your hand on the forehead and you tell them to push their head forward. So you're testing, their strength or their resistance and whatnot. You do it to the back of the head. You tell them to push against your hand. You place your hands on both the right and left side, and you have them either press against your hand, again, for the left and the right side as well. And then you also place your hands on both shoulders and make them do a shoulder shrug. And this again is cranial nerve 11. I don't know if I saw her do that. Let's see, what else? Also, I don't know if she did this either, but when you're checking for patency of the nares, of course you have your gloves on. So you close off one nair and have them breathe through their nose, and then you close off the other and see if there's some obstruction or whatnot. So that would be a way to inspect or to determine if there's a nostril patency or if there's an occlusion. All right.
We're also inspecting the patient's effort of breathing. Is it really labored? Are they using those accessory muscles to breathe? Also, we're looking at that anterior posterior diameter. So turn to the side like that. And you're looking for that barrel chest, and it will be increased in patients with like COPD. They will have what's called the barrel chest. And now what we're going to do is we're going to listen to heart sounds, and then we're going to listen to lung sounds. So first, let's auscultate heart sounds. And
like pathophysiology, you know how you learn with anatomy and physiology is the normal. And of course, when you take pathophysiology, or even in your textbook where it talks about that pathophysiology section, same thing here. In your health assessment textbook, it will show you the normal, what things should look like. And then, of course, it'll show you when things deviate, how it looks, or the abnormality when it deviates from that norm. For example, the AP, or anterior posterior diameter that she just spoke about, it should be only so far apart, the anterior versus the posterior. But when it has that barrel look, as in COPD patients, patients with respiratory disorders, you'll see that that anterior posterior diameter increases. All right. So I just want you guys to start thinking, not only is this good for now because you're in clinical and you have to assess your patients, but I'm trying to also give you that sneak preview as to what you can expect in the health assessment. So, you know, every little bit counts. And excuse me for my commentary. I just want to make sure as we talk about it that I make a comment, and that way you can remember it a whole lot better.
We're going to do this in 5 locations, and they're based on where the valves are located. And I like to remember the mnemonic: all patients effectively take medicine. And the first letter of each word represents the valve, except for effectively. So A would be aortic, P in patients would be pulmonic, effectively would be Erb's point, and this is just the halfway point between the base of the heart and the apex of the heart, and there's no valve location there. And then T is for tricuspid, and then M is for medicine.
Really pay attention to this one. This is so important that you know proper placement of listening to your different valve sounds, checking for murmurs. Remember, there was a question on your test where it gave you guys the image of this person, and it asks you where, if a clinician was assessing for aortic valve sounds, where would you place the stethoscope? So in this case, it would be on the right side, second intercostal space, and a pulmonic is just the opposite of that. And then, of course, you go down along the sternal border on the left side. Remember, the heart is on this side if you think about your anatomy and physiology. All right.
So again, using the diaphragm, we're going to listen at the right of the sternal border at the second intercostal space, and that's going to be the aortic valve. So to find that second intercostal space, find the sternal notch, go down to the angle of Lewis, then just go a little bit to the right, and you're in the second intercostal space. And this will be the aortic. And we're just listening, lub dub, S1, S2, and S2, the dub, is going to be louder in this location. Then we're going to go a little bit over to where the pulmonic valve is found. That's on the left of the sternal border at the second intercostal space, so we're just right across. Again, just listening to lub dub, and S2, dub is going to be louder in this location. Then we're going to go a little bit down to the third intercostal space, and this is Erb's point. And again, you can hear lub dub, but there's no specific valve here. Then we're going to go down to the fourth intercostal space, and this is where the tricuspid valve is. And lub, S1, is going to be the loudest at this location. Then we're going to go to the fifth intercostal space, mid-clavicular line, and we're going to listen to the mitral valve. And again, S1 is going to be loudest here, dub. And there's something special about this site. This is the point of maximal impulse. This is where you're going to listen for the apical pulse. So we're going to sit here and we're going to count it for 1 full minute. And a normal apical pulse in an adult should be 60 to 100 beats per minute.
Remember, when you're giving certain medications, especially your digoxin, you want to listen for 1 full minute, and this is where you will listen to the heart sounds. If that heart rate is less than 60, this is when you want to report it to the physician or nurse extender, whoever's covering, looking after this patient. So you hold it until you speak to them, and until they give you the go ahead to either give it or withhold it.
And his apical pulse was 63. Then we're going to switch over with the bell of our stethoscope, and we're just going to repeat in those locations, and we're specifically listening for heart murmurs, so that swooshing, blowing sound. So that's what we're going to listen to with that. Now let's listen to lung sounds. Now when you're listening to lung sounds, you're listening for abnormal sounds. And here are some samples of some abnormal sounds that you may hear. Crackles. Wheezes. A friction rub.
Sure, you all are also listening to, or you're listening and documenting what it sounds like on inspiration and what it sounds like on expiration. For example, inspiratory wheezing and expiratory wheezing. You just don't want to say expiratory wheezing. You have to mention or document both. And whenever we're talking about any breath sounds other than clear breath sounds, these are referred to as adventitious breath sounds or abnormal breath sounds. But adventitious is what you'll see in your textbook, and those are just abnormal breath sounds.
Or strider.
Sorry for the commercial. Sorry about that.
First, we're going to listen anteriorly. And what we're going to do is we're going to listen with the diaphragm of our stethoscope. And we're going to start at the apex of the lungs. And we're going to
also remember these different terms she's using: anterior, posterior, supination, pronation, inferior, superior, and so forth. Just remember all these different terms, because when you're describing and reporting in your documentation, you have to be able to use these terms. All right. You have to be able to use these medical terms that identifies the different locations and landmarks, if you will.
always compare sides and just inch your way downward and assess all the lobes of that right and left lung. So first, let's start up here, okay? And Ben, I want you to take good deep breath in and out. So here we go, apex. Okay, we're going to compare sides. Then we're going to move down to the second intercostal space, and this is going to help us assess the right upper lobe and the left upper lobe. So another deep breath in and out. Then we're going to go down to the fourth intercostal space, and we're going to assess where our right middle lobe is and our left upper lobe, because remember, the right lung has 3 lobes and the left lung has 2 lobes. So let's listen to our left upper lobe. We're just going to go down a little bit. Then we're going to go mid-axillary at the sixth intercostal space, and we're going to listen to the right and left lower lobes. So if you just want to turn to the side right there, take a good deep breath in for me. Okay, other side. And now let's listen posteriorly. Again, using the diaphragm of the stethoscope, you're going to start listening at the apex and work your way down. And one thing to keep in mind when you're listening back here, you have the scapula, and you don't want to listen over those because you won't be able to hear the sound. So you're going to listen in between where the scapula and the spine are, so down in these regions right here. And again, we're just going to compare sides, and you can do this part at the end if you wanted to whenever you turn your patient over to look at their backside, but we're just going to go ahead and do it now.
And this is what I was talking about, you know, what she just mentioned, you can do this when, in other words, if she's already there, just go ahead and listen to that particular area rather than have the patient going through all these motions. Also, in order to not, you'll see this in your literature as well, in order to not miss anything, you want to, your stethoscope should be going in a kind of a Z formation, like here, down, over, down, over, down, over, kind of like the formation of a Z when you're listening to your breath sounds. Sometimes also what they'll do is have the patient kind of hug themselves, and this will expand. This will expand the rib cage and expose the lungs, the posterior lungs. All right. The posterior lungs are not protected by the rib cage like the anterior body protects the or the anterior rib cage protects the front of your lungs. So the backside or your posterior lungs are just not protected. So it's easier for you to auscultate or listen to breath sounds in the back without getting that dampening kind of sound, because whenever the stethoscope is over bone, as in the ribs, or in this case, even the scapula, you'll get that dull kind of sound, and you want to make sure you're in between the ribs on the anterior portion, and of course in the back, that your stethoscope bell is not on the scapula, but is on the the fleshy portion, as you'll see.
And the apex. Compare sides.
She may do it a little different, but.
Then we're going to find C7, which is that vertebral prominence. It's the big ball right there. You can't miss it. And go down to about T3, and you'll be in between the shoulder blades, and go a little bit in between the shoulder blades and the spine right in there, and you're going to assess the right and left upper lobes. Then from T3 to T10, we're just going to inch around, and we're going to listen to the right and left lower lobes.
So she's not going in the Z formation, but the Z pattern is just another technique that you can use. This is not wrong, but your book tells you about the Z kind of a pattern.
Okay, now we're going to assess the abdomen. And remember, we're switching our sequence and how we assess. We're going to do inspection, auscultation, and then percussion or palpation. So we're going to do auscultation second. So whenever you're looking and assessing the abdomen, have the patient lay on their back. And what we're going to do is we're going to inspect the abdomen. And first I want to ask Ben, are you having any stomach issues at all?
No.
No? Okay, and when was your last bowel movement?
Yesterday morning.
Yesterday morning. And how are you urinating? Do you have any pain while you're peeing? Do you have problems starting a stream? Any discharge, anything like that?
Nope, it's normal.
Okay, and with your male patients, you want to ask about that due to prostate enlargement with starting a stream. And if he was female, I would ask him when his last menstrual period was, and also, again, ask the female patient about urinating and things like that. Now, if the patient had a Foley, this is the time when you would want to look at the urine, inspect the Foley, and look at that. Just conglomerate your urinary system and your GI system together.
Before you start, well, let me back up. So when you're assessing the abdomen, your sequence does change, and it goes from inspection, you're looking first, then you auscultate, you listen afterwards, because if you palpate and percuss first, if you try to auscultate afterwards, you won't get what is truly going on with the person's GI system, because you're manipulating the bowels in a sense. So you want to make sure you inspect first, and then then listen, and then you percuss, which will show you percussion hopefully, and then you palpate last. So remember, the sequence actually changes. And before you go pressing on this patient's belly or abdomen, you want to make sure they empty their bladder first. Otherwise, it might be very uncomfortable. And you can get your urine specimen at the same time when you do that.
Okay, so we're inspecting the abdomen. We're looking at the abdominal contour, and this patient's is scaphoid. It goes in a little bit. You can also have flat, rounded, or protuberant. And also, we're going to note if there's any pulsations. A lot of times in this area right here on thin patients, like with Ben, I can see the aortic pulsation in this patient. It's right above the umbilicus. And looking at the belly button and checking for any masses. Do we see any hernias or anything like that? Also, if your patient had any wounds, you would want to look at that. And if they had a PEG tube, you would want to assess the site, make sure it's not red, and ask them how it feels. And with your ostomies, you would want to look at the stoma and make sure it is like a rosy pink color. It's not a dusky cyanotic color, and it's not prolapse. And look and see what type of stool it's putting out. And note the smell. Note if the bag needs to be changed, anything like that. So now we're ready to listen to the bowel sounds. And what we're going to do is we're going to listen with the diaphragm of our stethoscope, and we are going to start in the right lower quadrant and work our way clockwise.
So remember, when she talks about the diaphragm versus the bell, this side here, let me see.
We're going to listen to all 4 quadrants, and you should hear. What we're going to do is we're going to listen with the diaphragm of our stethoscope, and we are going to start.
All right. So this would be the diaphragm on this side. I think there's a test question on your HESI about this. So this is the diaphragm, and this is the bell of your stethoscope. All right. So know the difference of different portions of your stethoscope. Diaphragm, bell.
In the right lower quadrant and work our way clockwise. And we're going to listen to all 4 quadrants, and you should hear 5 to 30 sounds per minute. And if you don't hear any bowel sounds, you need to listen for 5 full minutes. And you need to note, are these normal? Are they hyperactive or hypoactive? So let's listen. Okay, this is our right lower quadrant. We're going to move up to the right upper quadrant.
5 minutes is a long time, by the way.
Move over to the left upper quadrant. And then down to the left lower quadrant. And bowel sounds are normal. Now we're going to listen for vascular sounds, and you're going to do this with the bell of your stethoscope, and we're going to listen at the aortic, we're going to listen at the renal arteries, the iliac arteries, and you could listen at the femoral arteries if you needed to. So you're going to listen at the aorta artery, and it's a little bit below the xiphoid process and a little bit above the umbilicus. So about right here, and we're listening for like a blowing, swishing sound, which would represent a bruit.
Remember, a bruit, B as in boy, R-U-I-T, bruit. The same with your carotid, that whooshing sound that is going through a very small or stenosed area, that would be your bruit. And the same thing since you're dealing with the vascular system here.
Okay, and then we're going to listen at the right and left renal arteries, which is a little bit down from the aorta location. So here's the right. Okay, now note it, and then over the left. Then we're going to listen at the iliac, and it's a little bit below the belly button, right here. And this is the iliac artery. And then listen on the other side. And again, like I pointed out, you could listen at the femoral artery in the groin if you needed to. Now we're going to do palpation. First, we're going to do light palpation, then deep. And Ben, as I do this, please tell me if you feel any pain or tenderness. So first, we're going to do light palpation. We'll just start in the right lower quadrant and work our way around. And you're going to go about 2 centimeters. And you're just feeling for any rigidity.
Don't go too deep initially. Go more or less kind of light initially, and looking at the patient's face to see if there's any facial grimacing. Because if you press too hard initially, you could cause a significant amount of discomfort for your patient. Your textbook has you actually percussing first. You know, when you take your fingers and you place them over the patient's body part, and then you just tap on your finger. That's percussion, and that's usually done after auscultation and then palpation. But she seemed to kind of reverse it a bit. So yeah. So anyway, so it's light palpation before deep palpation.
Any lumps, masses, anything like that. How's that feel?
Feels fine.
Okay. Okay, now we're going to do deep palpation. And we're going to go about 4 to 5 centimeters, so a lot more deep. And again, you're just feeling for any masses, lumps, and Ben, tell me if you have any tenderness. And sometimes you can do this with 2 hands if need be, if you're not strong enough like me. Feeling anything?
No.
Feels nice and soft. Heard some belly sounds. That's why you do this after you listen, because you stimulate it. Okay, everything felt good. Now we're going to assess the lower extremities. So first what we're going to do is we're going to inspect. We're going to look at the color from the legs to the toes, making sure it's nice and pink. And here we see that Ben has a little bit of a tan line here. And we're looking at the hair growth as well. You want to make sure there's normal hair growth, because in PVD, you will see hairless, shiny, thin legs. And here we have excellent hair growth. And also, do you see any abnormal swelling just right off the bat before you've even touched the patient? And look at the legs and the feet for any swelling, redness, swelling. Do you have any pain or anything in your legs, anything like that? And look at the joints, make sure there's no redness on the joints, because a lot of times with gout, it likes to start out in the big toe, so make sure that everything looks good. And then on your diabetic patients, make sure you look at the bottoms of their feet, because these patients don't have the best feeling in their feet. So their shoes could be wearing on them, or they could have stepped on something and not even know it. So inspect those feet, make sure there's no ulcers or anything like that needs to be addressed. Also, look at the toenails. Do the toenails look healthy, or is there fungus, or are they missing toenails? Do they have a really bad ingrown toenail? So assess for that. Next, you want to palpate your pulses. We'll palpate the popliteal pulses, which are behind the knee. And those are about 2+, they're equal bilaterally. And I'm just feeling his legs, they're nice and warm. And I'm going to push over his tibia firmly, and I'm seeing if there's any edema. So push there. And if there is edema, a lot of times whenever you push down, it's like this hard-like type gel. It'll just separate, and your finger will leave this indentation. And here we don't have any. Now we're going to palpate on the feet, and we're going to feel on the pulses. And I'm going to don gloves, perform hand hygiene, don gloves, and we're going to feel on the pulses in the feet. We're going to feel on the posterior tibial. And 2+, really good. And then we're going to feel the dorsalis pedis, which is on top of the foot. 2+ with that. And if you can't ever find these, because sometimes these are hard to find in patients, you can get a Doppler if you have one on your floor. Next, I'm going to check the capillary refill on his toes, just like how we did with the fingers by pushing down. And less than 2 seconds. Check the other one.
Hey, just a side note. So the diaphragm of your stethoscope, it is best for high-pitched sounds, and the small portion of the bell of your stethoscope, that is used to listen to soft, low-pitch sounds. All right. So the diaphragm would be high-pitched sounds, and the bell would be for your low pitch sounds. and also the different assessment techniques that you will be using mainly as you're doing these assessments is let's see, assessment. Yeah, all right. So as far as your assessment techniques, so you think you just keep in mind inspection, palpation, percussion, and auscultation. And you'll read about all of these, but just make sure you're, you really, whenever you get into this class, of course, and even now, just make sure you understand what these different techniques mean and what they generally render in your assessment. This is almost over.
Okay, now I'm going to have him push against my hands. Push against my hands, Ben. Okay, good job. Now I'm going to have you raise your legs against resistance. Good job. Now we're going to check the Babinski reflex, and you can use your reflex hammer for this and use the end of it, or you can use your finger if you don't have that. And what we're going to do is we're going to take this up through the ball of the foot and curve it, and we're looking for the toes to curl in, which would be a negative normal response. So let's check that. Okay. Okay, and that was normal. Then we're going to doff our gloves and perform hand hygiene. And next we're going to assess the back. So whenever you're looking at the back side, you're going to look from the head all the way down at the back, and you really want to pay attention to any abnormal moles, lesions, wounds, anything like that, and assessing for skin breakdown, especially on your patients who are mobile. So that would really be concentrating on in the backside area.
Now, this is a great example of what I was showing you all earlier. Remember when she had the patient's back exposed, particularly when she was assessing or auscultating the breath sounds. She could have actually did the inspection of the back at that point. So here again, you don't want the patient continuing to switch and change positions throughout the assessment, because it could be very exhausting for your patients, and especially depending on what their health status is at that time. They may be very fatigued, very weak, and just don't have the energy to assume all these different positions. So again, as you can see, I'm sure this is this portion could have already been taken care of, but this is a good example of why I was saying if a patient is in a certain position, I mean, you want to do a systematic assessment, but at the same token, you want to also make sure that you're touching these areas, assessing these areas when the patient is in a certain position.
On the coccyx, that's where a lot of breakdown happens, and on the back of those heels, if you couldn't see it, whenever you were assessing the feet. And also you could, if you hadn't already, you could listen to the lung sounds as you have the patient over on the back. Okay, so that wraps up the nursing head to toe assessment. Now, please be sure to check out my other videos, because I have a lot of NCLEX review videos to help you study for NCLEX, along with other nursing skill videos, career tips, and everything.
All right, what do you all think about this video? Or what do you all think about the this assessment? Anyone?
It's all right.
Yeah, well, you know, it's good to see it. It's good to see it done like this, you know, so she can go into each area and explain what she's doing and everything. But remember, depending on what kind of floor you're working on, you won't have time to do a complete head to toe assessment like she did, but you'll just be focusing on certain things like, you know, their orientation status. You're listening to their heart sounds, their lung sounds, you're checking peripheral pulses. You're looking at a skin breakdown, You know, so you're not doing that complete, even with your cranial nerves. I mean, you're only doing certain cranial nerves, and you're doing it pretty quickly as well. You're not necessarily listening to abdominal sounds in the different quadrants for 5 full minutes. I mean, you may have to, but typically you don't have to. It just really all depends, because you can imagine that's 20 minutes, and no one really has time for that, realistically speaking. All right. Quickly, I want you to look at this video. It's only 1 minute and 46 seconds, but I want you to see how the lymph node assessment is done, because you'll see this again. Oh.
Professor, is there a sound to the video?
I'm sorry, what was that?
Is there a sound to the video?
A song?
Sound. We're not hearing anything.
You know what? I guess you have to do this each time, eh? Let me do it again. I guess it looks like you have to do it with each time. I didn't know that either. All right, you should hear it now. Tell me if you don't.
Palpate the neck. All the lymph nodes, I'm going to start with the pre-auricular, which means before the ear, palpating. When I'm palpating for the lymph nodes, I'm using the pads of 3 fingers, 2 to 3 fingers, and then just using kind of a circular motion, pre-auricular, and then post or behind, post-auricular, and then moving down to the tonsillar and submandibular, submental, right below her chin, and then anterior cervical. Posterior cervical is behind the sternocleidomastoid muscle. Deep cervical you can't feel until unless you have Miley go ahead and turn your head one way. And the way she turns her head, you'll want to kind of press into the sternocleidomastoid muscle, and you can sometimes feel a deep cervical there. Go ahead and turn the other way. But a lot of times the deep cervical are deep, so you won't be able to feel them. The supraclavicular, supra means above, so above the clavicle, supraclavicular, and infraclavicular, or below the clavicle. Finally, the occipital, behind the neck. Good. And you're feeling for any lymph nodes, which are going to be pea size or larger. If they are normal lymph nodes, they'll be mobile, they'll be non-tender. Sometimes they can be tender, fixed, and hard. Those ones are more worrisome and require further workup.
Yeah, I just wanted you all to see how they typically assess your lymph nodes. And so that's how you would be conducting or performing your lymph node assessment in class. All right, so you all will be looking at, let me see. You all will be looking at chapter 44 at myasthenia gravis. This is a pretty interesting disorder as well. So go ahead and take a look at that as far as your concept map is concerned. Go ahead and go to break now. Come back in 20 minutes. I need to go ahead and make sure you all can sign into your channels. So I'll go ahead and do that now. Anyway, so just be back in 20. Let's see. 26. Okay.
Professor, I got kicked out. Can you say the last thing you just said? I just got back in.
Take 20 minutes and your concept map would just be on myasthenia gravis. It's not that much reading, but there's a fair amount.
Okay.
Not too much though. And then you all can come back and start working on it.
Okay. And then are we meeting
At what
back
time?
at 2:30?